welcome everyone. This is our 11th Quality Cafe, and today I'm happy to announce that we are going to talk about pediatric readiness. So just a quick reminder about our Quality Cafe series. Each cafe includes a 20 to 30-minute learning session followed by question and answer. We have lots of awesome content today, so we might go a little bit over. We did book it for the hour, but if you have to hop off early, we understand, and you will receive the full recording afterwards. The goal of this series is to foster networking and shared learning across our quality professionals in Alaska. Oh, I need to change that. We're trying to meet quarterly this year. We're a little behind on the 2 months. These are the previous 10 topics that we've had. If you're interested in any of these topics, reach out to Debbie and or myself, and we can get those recordings and resources to you. So without any further ado, I'm going to hand this off to our guests. We have Renee from the state of Alaska, Ardith and Liz here as well, and I'm going to hand it off to them and let them speak.
Thank you very, very much. It's really a pleasure to be here. I am honored to be invited to speak today with Renee from Juneau and Ardith from AHHA's headquarters, and I'm in Philadelphia. I'm seeing some familiar faces, so shout out to Clifton and shout out to Ariel Tango. Good to see you guys. I used to work in Bethel, Alaska. So today we're going to be talking about pediatric readiness, specifically in the context of what's going on in Alaska, both in and outside of the tribal system. And we're going to also be describing a program with the How to Do Readiness that Ardith and I co-lead. And we are going to be talking about specifics of the program and potentially ways you can all get involved. Next slide, please. So the objectives today are to we'd love for you all to be able to define pediatric readiness at the end of this hour, describe the importance of becoming pediatric ready. And this really means both in the hospital setting and in the pre-hospital setting. We would love for you to have some pediatric ready resources at your fingertips that are free and openly accessible that you know how to access after this. And we're going to give updates on the IHS pediatric readiness efforts through the program that we're going to discuss. So I'd like to turn it over to Renee Escamilla to take it over and start off her presentation. Thanks.
Hi, everyone. Okay, so let's start with the basics. The Emergency Medical Services for Children program, or as you see on the slide, EMSC, is a national initiative funded through the Health Resources and Services Administration. Importantly to note, it's the only federal funded program dedicated solely to improving emergency care for kids. Other federal grant efforts touch on children as part of their broader emergency planning, like Hospital Preparedness Program, HPP. But EMS for Children is the one program whose entire mission is pediatric readiness, and which is why I'm introducing this to you now. The Alaska EMSC State Partnership Program is housed in Juneau, as said earlier. Next slide, please. So why does this matter so much in Alaska? Why is EMSC here? Well, our geography and demographics make pediatric emergency care especially challenging. Many communities are only accessible by plane or boat. Response times are often long, and travel can be really treacherous, especially with our weather conditions. Most frontline care comes from small hospitals, clinics, or even volunteer EMS crews, and not pediatric specialists. So this means that we have to make sure, as providers, that we are preparing our frontline providers and all of our clinic and hospital staff with the most advanced EMSC care we can. So these things so what EMSC does for Alaska is it brings these national best practices to you and maybe even recognizes your facilities for their job well done. And then we also try to bring practical tools to you. Next slide, please. So here's what Alaska EMSC is doing today, currently right now. So for in-hospitals, we're preparing for the 2026 Pediatric Readiness Assessment. And this will measure your how well emergency departments are equipped to care for children. Also, Alaska has a long-standing pediatric facility recognition program that highlights hospitals truly dedicated to pediatric emergency care. You'll see a couple of the facilities on the side of this slide right here that are already recognized. And we encourage other facilities to participate. If your facility isn't yet recognized, this is a proven way to demonstrate excellence and join those already leading the way. And I'm going to roll back just a little bit, and we talked about that pediatric readiness assessment. The last assessment that we had in Alaska that we submitted responses to, our score we received as the state was a 65. And so I'm hoping to see that improve this go round in 2026. Okay, so for EMS, we are reviewing baseline readiness scores that we collected in early 2024. And with these scores and what we find from this data, we are going to develop an ambulance ready program, which is going to be similar to the hospital facility recognition program. For families, we're creating tools to support care at home, especially for children with complex medical needs who are transitioning home from the hospital. And then finally, we're using technology. So the Office of EMS, in collaboration with the Hospital Preparedness Program, offers EMS license agencies the HandHeavy mobile app. And this app helps providers calculate dosages and run resuscitation safely for kids. And it also works for adults. So last year alone, it was used in over 5,000 calls across Alaska. And out of those 3,000 of those calls were pediatric emergencies. So all of this together, these efforts are raising the standard of care for kids across Alaska. And whether they show up in the emergency department, your local clinic, whether they're calling 911 from home or need support at home when they get home and they want to stay healthy in there. So what is pediatric readiness? The next slide will help you with that. So Dr. Sanso, would you like to take over, or Ardith?
I can take over. Thank you, Renee. So we just wanted to provide you a definition of what pediatric readiness is. It's really ensuring that our EMS, our fire rescue agencies and EDs are prepared with pediatric champions, with competencies, with policies, equipment, and all the resources they need to provide pediatric specific care in emergent situations. Next slide. And why do we want to become pediatric ready? Really, I'll just go with bottom line up front. Pediatric readiness saves lives. There are lots of statistics that show that being pediatric ready will lower the mortality and morbidity of children injured and ill. And working in the Indian Health Service, a huge portion of our facilities are in rural and remote areas. So not all children have access to specialized pediatric care. This is a national figure. 80% of children receive emergency care in general EDs. And for Indian Health Service, this is all of the EDs. And even for tribal facilities, we don't have any specialty hospitals for pediatrics. So it's really important that we really work on improving our pediatric readiness overall. Next slide. Sorry. So how do you want to become pediatric ready? Really, what you can do is start with navigating the National Pediatric Readiness Project website. They have a checklist, they have a toolkit, and then once you become familiar, go and take the National Pediatric Readiness Assessment. This is how you can find out what your pediatric readiness score is. And then from there, that'll kind of guide you on what gaps that you may identify in your emergency department. There are 7 domains: the administrative and coordination, healthcare provider competencies, quality improvement, policies, procedures, support services, guidelines to improve your pediatric safety. And then, of course, equipment, everything that you need to be pediatric prepared. And then the most important factor in being pediatric ready is identifying a pediatric emergency care coordinator. This is important because this individual, preferably a nurse and a doctor, they will work together to help guide and provide training and education to both service lines, so that nurses and doctors are working together congruently to improve pediatric readiness in your emergency department. The pediatric champion, having a pediatric champion is associated with improved pediatric readiness, improved decreased mortality. They help ensure compliance to guidelines, promote quality improvement, educate staff, and they monitor your equipment and supplies. Next slide. And so when is the best time to become pediatric ready? Really, the time is now. Once you have familiarized yourself with just the checklist, the toolkit, you've taken the pediatric readiness assessment, you've identified your gaps, really you can take that and talk to your leadership, try to get their buy-in and show them what your standing is as far as pediatric readiness. And then make the effort to connect with stakeholders across the board, local, tribal, state, and federal. You'll find that everybody will really want to help you to become more pediatric ready, to provide services, or even connect you with their networks. This is really a huge effort, and it really takes a village to improve pediatric readiness. I've been in my position for like 5 years now, and I haven't met anyone who doesn't want to improve pediatric readiness. I think once they really understand, once they really see the benefit of your effort, then it's you're saving lives, you're saving children's lives. So it's really really beneficial. And then just to keep furthering and increasing your knowledge, I recommend reading the pediatric readiness in the emergency department joint policy statement put out. And this is super helpful to kind of give you that overall understanding of pediatric readiness, kind of the national standing, where everybody is, and just the collective national effort, I guess I should say, that everybody is really trying to put forth. Next slide. And so how is IHS becoming pediatric ready? What we're doing is working with Children's Hospital of Philadelphia. We partner with them for going on 5 years. We've developed a hybrid stipulation program that is really, I'm sorry, next slide. You can go to the next slide, sorry. There we go. We are really trying to develop a curriculum for an interdisciplinary emergency department team. We have every facility identify a pediatric champion, both a nurse and a doctor. We partnered them with the academic medical centers, either locally or if we can find one who's interested. It doesn't have to be locally, but preferably locally. And then we're partnering with the state level EMSC managers. This is important because they often don't really know what we're doing, and in order to not duplicate effort, it's really helpful that you connect with them, you partner with them, and everybody shares resources. We also try to really include the pre-hospital EMS as well, because oftentimes, where does the emergency start? It starts outside of the ED doors, and it's their first responders, and they're bringing our patients to us in the ED. So it's really important to try to loop in the pre-hospital EMS agencies as much as possible, either tribal or local. Next slide. And right here, I'm going to go ahead and hand it off to Dr. Senzo.
Thank you, Ardith. So I hope you all are with us to this point, and I think just a little check. Will you please react with a thumbs up or a heart if you are actually a PEC or a pediatric emergency care coordinator in Alaska or anywhere? I want to see if there are any PECs on the call right now. Oh yeah, those are the ones I expected. Okay, good. Those are the ones I know. Thanks, guys. So I will continue to explain a little more about that IHS MSc Hybrid Sim program that Ardith just started to explain. And really this program is a program that you can join to how you can address your pediatric readiness. So Renee gave a really nice overview of the National Pediatric Readiness Program and online free and openly accessible resources that you can go to right now for your pre or in-hospital teams to really start using the toolkit, looking at the checklist. If you want to take that National Pediatric Readiness score, Renee would love it if you took that. She's really looking to bring the state of Alaska number up from that 60s on all the way up to at least above 87, because that number of 87 is the sweet spot on a pediatric readiness score where studies have shown that you have improved morbidity, mortality for ill and injured pediatric patients, both at time of arrival and a year out. So I think, Renee has her work cut out for her as the program manager in the state of Alaska. And if you're able to work with Renee in Alaska and we provide a program that we can help support to get you there, you can bring that number up to 87 and really start saving lives in Alaska. So by the numbers, who's in our program right now? We have 19 participating federal IHS healthcare facilities, and this includes also some tribal sites as well, including Maniluk, Hay, Ariel, Tango, Peckout, and Maniluk, and Kotzebue. And we have one state EMS agency, and guess what state that is? That's the state of Alaska. So Mike Levy has said that he wants this to be a part of the program and for EMS folks in Alaska to connect to the program as much as possible. So please, if you work in EMS at Clifton, reach out to us. We will get out there and we will help you with your pediatric readiness pre-hospital. We try to collaborate with any federal program who is funded to do basically similar work. So we really try to, great, see you soon, Clifton. We really try to align each other's efforts. So we work very closely with Renee. I think Renee and I have been working together for at least 5 years, maybe 6. And any site in Alaska who is part of our program has gained facility recognition from their program's headquarters. And that is a huge, and maybe in our discussion, we can sort of talk about what that means for the PEC and at the institution level, if anyone wants to share. But it really is a stamp of approval from the state and really from the nation that you are ready for any pediatric patient. You have the basic preparedness for any pediatric patient to show up to your ED, and that should be a badge of honor, pride. We collaborate with 13 academic medical center partners as part of our program. Now, as Ardith spoke about, we really try to pair those pediatric emergency care coordinators pre and in hospitals with an AMC partner who is usually a pediatric emergency medicine physician or pediatric critical care physician. And we try to make them the regional academic center. So where you would refer a patient to: University of Minnesota, University of New Mexico, Seattle Children's Hospital Philadelphia, where I work right now in the pediatric emergency department, does have a few AMC partners for some sites who specifically wanted a non-regional AMC partner, and we just try to find a nice match. We have found that partnership is actually beneficial, not just for running the curriculum, I'll get into what the curriculum is, but really also linking folks to resources if they need specific resources. So they need some help with their PDSA cycle strategies for their quality improvement project. Like sometimes people want help from their AMC partner and they sort of link them to resources. Sometimes people want help from their pharmacy for protocols or guidelines, and that partnership sort of helps with follow-up for what we sort of identify with simulation as part of our program needs, and then the AMC partner sometimes is able to bridge those needs. Overall, for the program, in the 5 years that the program has existed, we've improved the pediatric readiness score for the EDs from a 73 to an 87. So we've actually, as of this year, we just crunched the numbers. This is new hot off the press from last week. Our number's at 87 now. So that again is that magic number where you start to see real improvement in your pediatric patient outcomes. The program, we have 19 sites. We didn't start 19 at once. We started with 6, then we added 7 more, and then we've added 1 site every year. And actually, to be honest, we have a waiting list right now, but that doesn't mean you can't reach out to Ardith and myself after this to talk about how you can be engaged in the program. We're constantly looking for ways to really sustain and scale the program. As part of the program, there are 9 Symbox Train the Trainer sessions. So what Symbox is, if you haven't heard of Symbox, you can go ahead and Google emergency Symbox now or after this, but that is the way that is the free and openly accessible web-based tool that we have, that we create and use for this program to standardize the way that everyone is running their own simulation-based trainings, not just for medical education, but really as a probe for the system to probe those quality issues that come up with pediatric readiness, and then debrief to really fill in the gaps. We have run 100 simulations for over 400 participants with at least 11 different cases. We pick cases 100% based on what the PEC wants. So we show up to the site, the PEC says, hey, it's almost October. We're going into bronchiolitis season. Like, oh, holy moly, we have a bunch of new people here. We really need to make sure that everyone has a standardized approach to how to triage and start treatment for that baby with bronchiolitis. Let's do bronchiolitis case. So that's oftentimes what we're doing now. Summers, oftentimes we start doing the trauma cases. We are always sort of trickling in the anaphylaxis seizure. It basically depends on what the PEC wants. Oftentimes when someone has a newborn delivery in their ED or on their helicopter, they want to be doing that sim over and over. So we do that sim over and over. So it really depends. We're not strict with we don't decide what we want to do. We have the PEC decide what they want to do, and we come in and help facilitate that. All of the participants recommended these simulations to colleagues, and all the sites were able to complete the full core curriculum. And then unfortunately, only 1/3 of our sim participants complete the survey. So we always encourage the survey. So that's a note after this presentation today. You will be asked to complete a survey. And please go ahead and do so on behalf of this Quality Cafe. Go ahead and go to the next slide, please. So things that we have learned. So it's one thing to say, hey, there's a National Pediatric Readiness Program, and here's these online tools, and go ahead and do it. And by the way, do your score and improve it. Then there's one thing to develop this program that really is meant to try to do the pediatric readiness with you, to support you to do your pediatric readiness and sort of provide some support, some mentorship, really bi-directional mentorship, and just some practical ways to start tackling the pediatric readiness. And we've, of course, learned that we are, developing a program that is in a real life, and it's being administered with real life settings with real life issues that make implementation of a program challenging sometimes and also really fun. So we've learned that those sites that have really strong hospital leadership, both at the ED department level and beyond at the C-suite level, that those are the sites that really say yes to pediatric readiness, that support the pediatric emergency care coordinator. And we have found that other sites that perhaps have more flux with their leadership aren't quite able to commit to saying, we're going to have a pediatric emergency care coordinator and therefore someone to interact with the program and interact with the state EMSC program. And those sites seem to be the ones that struggle a little more with prioritizing pediatric readiness and then deciding they're going to make a leap and do something about it. We at the IHS headquarters level, we're always trying, really Ardith is spearheading, trying to really make sure that everyone at IHS headquarters is aware of the pediatric readiness movement. I was up in Anchorage last week at ANMC, really talking about pediatric readiness from an ANMC level. So I might want to ask after this talk today is, if you do treat pediatric patients where you work, please go ahead and start the dialogue with your leadership on what you're doing for pediatric readiness, and then reading about the PEC role and exploring if you can actually start developing a PEC role at your site. We have noticed that having dual PECs, so both that dyad of physician and provider, really does help with the education of the pediatric readiness. This is, I view this as very much a nursing-led initiative. If we don't have, I have found that at sites, if they don't have a strong nurse leader, often, let me put it this way, if there's a strong nurse leader, everything else follows. If you just have a physician leaders, everything else doesn't follow. And if you have a dyad, then you're like set up for true success there, because oftentimes we come in and we say we want to do the simulations, we want to simulate for finding your gaps in pediatric readiness, and then we want to actually follow up on it. You could imagine who is actually going to come to the table. If PECs are reaching out from the nursing and providers, you're going to get more of an interdisciplinary crew there paying attention to the topic. So we very much, and the National Pediatric Readiness does support a dyad model if possible. And this doesn't include APPs here, but APPs are some of the strongest PECs that we have across the program, who really sort of speak both languages very clearly. So I am an advocate for the APP PEC. Codifying the PEC position in a job description is really a facilitator for PEC, both acquisition and sustainment. So then therein, of course, lies that leadership. So if a leadership buys into the PEC position, is able to write it into your job description, then theoretically you have some time that's actually dedicated to that. And that is definitely a facilitator of continuing pediatric readiness at your site. And if you feel empowered to request administrative time for PECs, there have been several studies published that show that retention of PECs is oftentimes linked to having actually some protective time for their role, which obviously is not really a big surprise probably to anyone on this call. So more lessons learned are we really are collecting data and analyzing what to justify basically the federal government continuing to support our program. So we do simulations, we collect simulation checklists from the facilitators, saying that they did the simulations, saying sort of if they met the checklist learning objectives for the simulations and tracking them over time. And we also collect data from the participants who participated in the simulations. Did they like them? Would they recommend them to people? Did they feel like these improved their communication, teamwork, psychomotor skills? But really, most importantly, we asked, did they feel like they, after doing the simulation, felt like they had the stuff, so the pediatric emergency blood pressure cuff? Did they know how to get the suction? Did they know where to find their cognitive aid? Did they know where to find that transport policy? Like the stuff that is made of that pediatric readiness score, we really focus the debrief on that, and not just the medical objective of give IM epi, say, for anaphylaxis. So that's sort of how we structure our simulations. And then part of this, I believe part of the success of how we've been able to grow and sustain and keep 100% of our programs over the last 5 years is the network for collaboration. So I believe in the power of PECs who work in different settings, but part of a similar healthcare system, joining together on scheduled quarterly meetings like you're all doing with these meetings, engaging with their AMC champions over text regularly just to debrief about the crazy pediatric patient they just saw. That actually really, I think, helps prevent burnout, helps with wellness, and helps sort of keep folks going together with the challenges that come up naturally with pediatric readiness. And so this, I'm speaking very specifically to the IHS and tribal context right now, just because that's the program that I co-lead with Ardith. But you guys are an audience of Alaska. So really reaching out to Alaska at large, finding other hospitals that can connect with each other and champions at the hospitals to really connect with and share how you're experiencing similar things with some nuances, but that you should not be reinventing wheels. You should be learning from each other and sharing policies, sharing protocols, sharing those things, sharing how to find hard to find small blood pressure cuffs. Where do you order them? There's a shared knowledge that happens when you join a group, and that's what really we're trying to establish with this program. And then part of the lessons learned is we like to nominate and give people awards and accolades for all of their efforts, and we try to really connect this as much as we possibly can to the national level awards as well. Go ahead for the next slide, please. So more successes as we just really, I understand we're at time and I really want to actually engage in a conversation with you all. But we have a pediatric readiness core curriculum and set. So what it happens, let's say you want to join the IHS SIM program. You basically, if you are a pre-hospital group that treats American Indian Alaska Native patients, or you work at a tribal facility, you can join, and you have to say you're going to have a pediatric emergency care coordinator, and thereafter it's free. So we show up, we connect connect you to an AMC partner. We have an engaged curriculum with simulation both in person and remotely, where we train the local pediatric emergency care coordinator to become the sim facilitator and the expert sim facilitator to run their own simulation drills with that debrief to probe pediatric readiness. We provide a report out after an in-person visit where we review your pediatric readiness score and how those simulations went and what was identified in the debriefs that could be optimized for a pediatric readiness smart aim and a PDSA cycle. And then our program follows up with some consultants to achieve those stated goals. And then we ask to connect twice for telesims throughout the rest of the year. And then we connect virtually with a cultural talk once a year. And we connect virtually with having you all connect with your state EMSC and the other program participants. So we, again, have found that overall, we have found that people sort of not just increase their pediatric readiness scores, but don't burn out as much. And we've had a lot of sustainment in the PECs across the program. You can go ahead and go to the next slide, please. So this is just a list to show you that, awards and accolades are really important. I share this not to show off all the people from the program that have won awards, because that is why I like to show this, but also sort of as a facilitator of supporting people who are working on pediatric readiness. If you have internal hospital or statewide awards, recognizing people who are these champions, because every site and every pre-hospital agency has one. They're really that person that people want around if there's a sick kid. Thinking about promoting them for an award and recognition of some sorts really keeps people going, and also can help with leadership recognition that this person is doing a lot for pediatric readiness. Go ahead and next slide, please. So one of the learning objectives stated at the top of this hour was to really make sure that you could walk away with some resources in hand, because you're not going to remember really anything that I'm saying right now. So what I would recommend is that you go ahead and do know about the EMSC EIIC website, okay? And Renee Escamilla is your friend to demystify this and what it means for the state of Alaska. And the Emergency Sim Box is this sim website that we create that is really meant for anyone to pick up and run with. So it's meant that anyone with any level of experience running simulation drills for education, QI or otherwise, can pick it up, read the facilitator guide, read how to do it, and actually just start doing them without the need for any fancy simulation facilitation training or anyone to hold your hand to do it. Then this Improving Pediatric Acute Care Through Simulation program is really the evidence-based program that we have adapted the IHS SIM program from. So the IMPACTS website, which has a ton of resources on all things pediatric readiness, SimBox, how to engage with pediatric readiness at your site, and the IMPACTS group and IHS Sim group are very excited to meet other people who are very interested in this work. And please feel free to reach out to us at any time if you're interested in just trying to figure out how you're going to start going with Peds Ready. Next slide, please. Here's more references. I believe these slides they're recorded and they'll be shared with you. So you can go ahead and link on these slides. And then there is an article there specifically about pediatric readiness, improving patient outcomes, and specifically about how SimBox has been used to improve pediatric readiness through telesimulation for nurses in the community emergency department. And again, referring you back to EMSC, IMPACTS, and MPRP. Lots of acronyms here. And so I hope that you're not afraid of the acronyms after this, and that you're able to say, okay, I'm terrified of the next sick kid. I know nationally there are resources for me because everyone's terrified of the next sick kid. So those are EMSC, NPRP, and hey, there's a lot of sim programs and some free tools to help me get there. And they're all on this slide. Go ahead, next slide, please. So I'm going to just breeze through these, but basically PECs think that it helps them when they practice things. Go ahead, next slide. And this is Soatsi Medical Center saying the same thing. So they've been getting great feedback from nurses and providers for the sims that they're doing. They do get a mannequin part of the sim program, and they've been able to use that both in the sim program and for skills training on infants. They get excellent feedback doing their own sims from people, even when we leave, actually. They're facilitating their own sims at the PEC level. Things that come out of the simulations include suggestions on where to store equipment, suggestions on new equipment they might not have had, and constructive feedback on communication and flow. So I sort of have breezed over this, and I hope to get this into this more in the discussion if it's something people are interested in. But really, this is a program led and run by folks who have pediatric readiness specialty simulation based for education skills to share and teach, and content expertise. And the quality improvement piece comes into, we are really using the sim debrief to probe. And so we will debrief after the simulation. We will create a smart aim with the PEC. We'll have that really try to be smart, and we'll really try to help facilitate a PDSA cycle that they can really then bring back in a timely fashion to say, hey, we were able to do this. Now let's move on to the next one. And this is not data we're collecting for any national research program. It's really meant for the internal purposes, and it's meant to be useful for the PEC. And here's just another quotation from the AMC partner here at Children's Hospital Philadelphia, who works at White River. And she has been saying, she's singing the accolades of the local PEC. She's saying that they requested more practice with similar scenarios, and they have continued to tackle, different cases during a time of year that they have wanted to tackle with the AMC PEC partner as part of the program. Next slide, please. So here's our contact information. Ardith Aspas is the nurse consultant for EMSC, Emergency Medical Services Children, at the IHS headquarters. I'm pediatric emergency medicine here at Children's Hospital Philadelphia. I used to be a pediatric hospitalist in Bethel, Alaska, at the Yukon-Kuskokwim Health Corporation, where I learned, I think probably most of what I learned was from Clifton. LifeMed, those LifeMed trips get your blood pressure up pretty fast, and I learned a ton from Clifton, so thanks, Clifton. And then now the Renee Escamilla has been an incredible partner at the Alaska EMS for Children program. She is the public health specialist there, leads it up. You will be hearing from her, if you haven't already, on how to engage in pediatric readiness in the state of Alaska. So without further ado, I would really like to turn it over. I'm sorry we've gone 8 minutes past the 30 minutes. Turn it over to a discussion, any questions you have. I'd love to have this be just a very interactive conversation with whoever is still left on the call. Thank you.
I'm sharing so we can see each other. Anyone have any questions or comments for the team here?
I will say Ariel Tango is an incredible pediatric emergency care coordinator out in Maniluk in Kotzebue, and they are a site, and Tango, if you're on, I want to speak to it, but they're a site that has incredible leadership buy-in. And that leadership, I think, has really paved the way for Tango to lean in as a PEC. And they were able to become facility recognized within a year of doing their program. I think the organization was ready for it. I think they had the perfect PEC for many reasons there. So Tango, really nice job. And then Ariel Tango is also engaged in actually now promoting the pediatric readiness of the 11 village clinics that the Maniluk Health, that basically encompass the Maniluk healthcare system out there, which is no small task. So there's always something to work on. I'm wondering, Tango, if you're on, and if you have any stories to share from being engaged in pediatric readiness in Maniluk.
Hi, can you hear me okay?
Yeah, perfectly.
So, yes, I have tons of stories, but for the sake of time, I'll keep it pretty short. We do have incredible buy-in from our administration. They're very patient-centered care focused and patient outcome focused, as opposed to like throughput metrics, things like that. And anybody who's ever worked in remote villages knows the horrifically tragic stories that occur from there. The PDSIM program and the Peds Ready program has really given us like a structured platform to prioritize our goals, because when you're in this role, it's real easy to see everything that's wrong, but it's really hard to prioritize what needs to be fixed. In addition to that, having our academic medical center partner, which is Dr. Maloney from Seattle Children's. And, that is one of our external referring facilities. I think having a facility that is aware of the unique challenges and, health disparities and everything that happen in remote Alaska has been a huge help, especially with coming up with like school asthma plans and a lot more of that preparedness instead of response strategy. At this point now, especially with EMSC, we're starting to pilot EMS programs in villages, working with women's health. You hit the nail on the head with the process issue compared to medical issues. People are medically trained, and in our region, we have a partnership with Mass Gen in Massachusetts. So like Harvard doctors come up here that are incredibly experienced and skilled as physicians, but the process here is very nuanced, and so is how we treat patients. And the golden hour doesn't exist in Alaska. So learning how to articulate all of that into the best possible scenario has been a huge help. More than anything, though, I think you guys coming up here for the site visit made a world of difference in increasing collaboration with OCS, to the point that now we're working with ANTHC to, and this is a big PEDS disaster preparedness thing. So anybody who's on this call in Alaska and works for THO, please feel free to reach out to me privately, because what we're working on is improving our guardianship verification status in the case of parents who are gravely disabled, or reunification after a disaster event. And things happen, especially with fires and whatnot. But I'd really love to open that up to anybody who would like to be a part of it, since it's potentially beneficial to the whole state to work with OCS. But a lot of those initiatives and having those contacts with you guys, especially getting lessons learned from places all over the country, has been incredibly helpful. But definitely hard recommend setting aside that administrative time. It's needed, because there's a lot that goes into it.
Thanks, Ariel. There is a lot that goes into it, and so I think that trying to demystify, just make pediatric readiness sort of break it up into bite-sized chunks is really what we're trying to do as a program, so it doesn't seem overwhelming. And I think taking it in bite-sized chunks is totally okay. And everyone has different bite sizes that they can take at their site. And I think that's okay. And just knowing that's okay, and knowing that you're making an effort versus not doing anything, is really important. If you want to go big, I'm putting in the chat the NPR-QI. So again, I'm aware this is a very QI savvy group. The National Pediatric Readiness Quality Improvement is basically the quality arm of National Pediatric Readiness Program. And some sites have had success going through their program and joining and being a part of the NPR-QI. And our program is in very close discussions with the leadership of NPR-QI to formally collaborate and adapt our program to have a major part of our program be NPR-QI. So really using Power BI dashboards that are linked to certain simulations that we're running, say respiratory distress or TBI or seizure or, triage or transports. These are sort of the national measures that were picked as the priorities. And then they're actually developing out maternal and OB measures as well for the NPR-QI. And we have those simulations on the SIMBOX website. So we are going to be moving towards a partnership, hopefully, with them. Stay tuned. And so right now, while we sort of in our program do debrief for QI, and we have PECs identify their own SMART aims. And so we're really trying to use that QI as the link, not just you simmed and you did this, but now you used it to probe the system, and now you're actually working on something. And we're trying to figure out a way to more formally collaborate with that other national federally funded program. So anyone who might be interested in that aspect, I would really invite your input and your site to really start exploring those methods as well.
Any other questions or comments? I really appreciate you guys coming on and sharing with us today. And we'll obviously get the recording and the slides with all those links out to everyone who registered today. But, you know, encouraging everyone at your facility to reach out to Renee, especially Renee. She's our state person and she can totally help you get started on this journey. So with that, we're going to close. There's going to be a little survey for you to do. It's just a real short couple questions, and I'm hoping we can schedule one more Quality Cafe before the end of the year. November, December timeframe. I know with holidays it's kind of challenging, but if anyone has any ideas for the next Quality Cafe, please reach out and let me know. Thank you, everyone.
Thank you very much.